Okay, welcome everyone to this evening's Transfer of Care Around Medicines, or Tcam, launch event. Thank you so much for giving up your time to be here this evening, and I hope you find the information we're going to share with you tonight both interesting and informative. Tcam is going live at the Royal Berkshire NHS Foundation Trust, and this event is primarily aimed at those working in community pharmacies in the surrounding area. But colleagues from across the Thames Valley are also joining us, as this will affect their patients too. My name is Matthew Epton, and I'm the Clinical Innovation Adoption Manager at the Oxford Academic Health Science Network, and I've been assisting the Royal Berkshire NHS Foundation Trust and the Thames Valley LPC with their Tcam initiative. Next slide, please, Sam. Before we start, I just need to mention a few housekeeping rules. Firstly, we'll be recording this meeting for training purposes, and a recording will be available for those that couldn't make it tonight. So if you don't wish to participate in a recorded event, then you should leave the meeting now. To avoid background noise, please mute your microphone. Your microphone will have been muted as you entered the meeting. Because of the online format of the meeting, we'll be taking questions at the end. However, please use the chat function in Zoom to type any questions that come to you during the presentation. We'll collate these questions during the meeting, and we'll try to answer them at the end. And finally, if you find that your internet connection is slow, try turning off your video stream, as this will free up your bandwidth and may improve things. We've got some really good speakers for you this evening, but unfortunately our first speaker, Sako Hussain, the Chief Pharmacist and Clinical Director for Pharmacy at the Royal Berkshire NHS Foundation Trust, can't be here with us tonight, but he has recorded a brief message which we'll play for you in just a moment. Following that will be Clare Howard, who I'm sure many of you will already know. Clare's the National Lead for Tcam and the Clinical Lead for Medicines Optimisation at Wessex Academic Health Science Network. Alison Freemantle will follow Clare, and Alison is the Professional Services Development Manager at Community Pharmacy South Central. But before that, she worked in the community pharmacy that had the highest number of Tcam referrals from the University Hospital Southampton NHS Foundation Trust. So I'm sure you'll be pretty interested in to hear about her experiences of Tcam. We're then going to hear from Adi Ukoha, who is the Associate Chief Pharmacist, and then Anand Pankhania, the Senior Lead Pharmacist, Clinical Services, both of whom work at the RBH. And last to speak will be David Dean, Chief Executive Officer of the Thames Valley LPC, whom I'm sure you all know very well. So let's move on now and hear a few words from Sako Hussain.
My name is Sako Hussain. I'm the Trust Chief Pharmacist and Clinical Director at the Royal Berkshire NHS Foundation Trust. And I would like to welcome you to the Tcam launch event this evening, 26th of August. Firstly, my apologies, I could not be at the event in person due to a prior commitment. So I've taken this opportunity to record a short message in support of the initiative. Before I say much more, I just want to sort of acknowledge and extend my gratitude to a number of colleagues who have helped make this a success. Firstly, Matthew Epton, who's the Clinical Innovation Adoption Manager at the Oxford Academic Health Science Network, for being very patient with us over the last year or so and really helping us drive this initiative forward. And without the support of Matthew and without the support of the Oxford AHSN, we may not actually be having this meeting this evening. Also want to sort of thank David Dean and Pharmacy Thames Valley for their support throughout the whole process. And indeed, my colleagues at the Royal Berkshire Hospital, NHS Foundation Trust, Adi Ukoha, Sam Bandukumara, the pharmacy management team, and countless other people who have been involved with making the Tcam initiative a success. I believe we're also joined this evening by at least two other individuals who are supporting the event. First person is Clare Howard, who needs no introductions, who is the National Tcam Lead for Pharmacy. And also we've got joining us today, Alison Freemantle, who's a retail community pharmacist who's got a wealth amount of experience on Tcam. So just to say a few words about the actual initiative, transfer care around medicines, the concept has been around for a number of years now, and it really reflects what we all know and understand about the transfer of information and medical medicine advice at the interface, be it from patients coming to the trust or for patients leaving the trust and going back into the community. We are very aware of the unintended consequences which can happen at those interfaces, and the Tcam initiative goes quite a long way in helping address some of the challenges we are seeing. What you will hear later on this evening is some of the information and research that's been conducted over the last 20 years at least, and more recently work that's come through Newcastle, clearly identifying the benefits of the Tcam initiative in reducing hospital admission rates and also in parallel supporting the patient's understanding and use of medicines. Just focusing a bit on the detail, so our community pharmacy colleagues are very well aware of the Medicines Usage Review, the MUR, and the NMS, New Medicine Service, and the Tcam initiative will fall within that. So there's a platform supported by Pharma Outcomes, which will help our hospital pharmacy colleagues to make referrals. I won't go into too much detail around the referral process and how it works in the community pharmacy sector. And there's a lot of information that will be provided today, and I'm sure there'll be opportunities to ask questions and to clarify thoughts as well. So needless to say, firstly, just a massive thank you again to our pharmacy colleagues in primary care at Oxford and within the Trust. I would encourage individuals this evening to ask questions, to get involved, to learn more, and to really understand and embrace Tcam, to ask questions of our national leads and to help understand the initiative. As Chief Pharmacist and Clinical Director, I would like to offer my support to the Trust and to endorse this initiative, as I'm sure would David Dean and the Oxford Academic Health Science Network. So I'm sure it's a lovely evening, I'm sure. Do get involved, ask questions, and we very much look forward to working with our partners in the interface and really taking Tcam forward and making it a success for our patients and partners alike. Thank you very much.
Okay, so this evening you're going to hear a brief introduction to Tcam and why we're doing it. You'll hear about the evidence that demonstrates the clinical effectiveness of Tcam and the benefits that it gives to patients. We'll talk about the national policies that underpin the implementation of Tcam, and we'll hear first-hand feedback from a community pharmacist about the benefits that both you and your patients will experience. The Tcam process is quite straightforward, and we'll hear how it works from both the acute trust side and the community pharmacy side. And then we'll finish off this evening with a questions and answers session. So what is it? Simply put, Tcam is a process that shares information about a patient's medicines with their community pharmacist when they leave hospital. This has been a joint project between Thames Valley LPC, RBH, Oxford AHSN, and Pinnacle Health Partnerships. That's the company that supplies the Pharma Outcomes platform. So I'm now going to hand over to Clare Howard, the National Tcam Lead.
Good evening, everybody, and thank you very much for giving me the opportunity to talk to you today about our experience around the country so far with this transfer of care around medicines initiative. People always say, oh, Claire doesn't need an introduction, but I'm guessing there are some people who don't know that actually I live in West Berkshire, I live in Newbury, I'm a patient here, so I have a vested interest in this service being delivered well, because one day it might affect me or those around. So let's just focus on patients for a moment and just think about what happens to patients at the interface as they move between sectors in the NHS. The evidence base shows us that about 60% of patients have 3 or more changes made to their medicines during a hospital stay. And a number of papers have highlighted that the transfer of care process is associated with an increased risk of things going wrong as patients move across the sectors. And indeed, the World Health Organization has produced a document around the transitions of care and what happens with medicines as part of the global health challenge around reducing harm from medication errors. And it's a really interesting read that spells out all of the things that many of us know from our day-to-day practice, but really highlights the problems that patients experience. So 30 to 70% of patients experience an unintentional change to their treatment, or an error is made because of a lack of communication or miscommunication. And you as community pharmacists, I know, will have been involved in all of this, in understanding what happens to those patients as they come out of hospital. We know sometimes patients are discharged late at night in a slightly chaotic situation on occasions, and they don't know what might be happening to their medicines. And you as their community pharmacist are often involved in picking that up and working out what the version of the truth is, if you like, around their medicines. I think on a very, very human level, I try and think of it as this information around only 10% of our older patients will be discharged on the same medicines that they went into hospital on. And the kind of outcomes of that can be catastrophic for some patients, especially where they live on their own, are in cognitive decline, or their carers are worried about what the new tablets might be and how they're supposed to be used. And we also know that 20% of patients have reported to experience an adverse effect within 3 weeks of their discharge from hospital. And when those have been analysed and root cause analysis done of those incidents, over 60% have found that those incidents could have been ameliorated or avoided if we had better systems in place for transferring information when we discharge those patients. So the evidence is stark, and we now have the beginnings of understanding what we can do about some of this. So Sam, if you wouldn't mind moving on to the next slide. I'll give you a little bit of background about where this work came from. So this isn't a particularly new initiative. Back when AHSNs first started, which is about nearly 7 years or so ago, a number of AHSNs under their medicines optimization programs were working with local trusts, trying to work out how we could communicate information about medicines to the community pharmacists to see if by doing that we could reduce all of the facts and figures I've just given you. And there was work ongoing in Newcastle, but there was also work in the Isle of Wight and Derby and other areas trying to work out whether this had an impact. And the first study to be published was this paper here in the BMJ Open. This was the Newcastle experience. Newcastle had a setup where they had very few limitations on who was referred, and actually the proportion of patients who were referred who received the community pharmacy intervention was only about 30% of the first 2,000 or so referrals. But the statistics were overwhelming, and actually the patients who received the community pharmacy intervention had statistically significant lower rates of readmission at 30, 60 and 90 days post-discharge. And those numbers are really important because in terms of the system, there are financial penalties and there are consequences for having patients come back into the hospital so soon after being discharged. At the same time as this work was coming towards publication, we had a study going on in the Isle of Wight, which was a higher risk group of patients. So these were reablement patients, and they were given a suite of support interventions. And about half the group got the whole suite of interventions, including the community pharmacy visit, and half didn't get the community pharmacy visit. And we were able to demonstrate from that the community pharmacy intervention had a powerful effect on readmission rates. It also had an effect on patients who were readmitted, and their length of stay was found to be shorter. So over the following few years, we started to ramp up this work and spread it to more and more trusts. And 3 years ago, we approached NHS England to say, well, formally commission us to spread this across all of the AHSNs. There was a lot of work being done in the Northwest on this, and we knew how to roll this out. And so all AHSNs were charged with working with community pharmacy and hospitals to start to make this a reality in a large number of trusts. So if you go on to the next slide, Sam. So over the following years, we've worked really, really hard to make this happen in a large number of hospitals and supported lots of LPCs to make this a reality. And I'll give you some of the data on that in a moment. But what's really important for this now is, as we were doing this work over the last few years, we had no policy levers to make this happen. So we were really working at the goodwill of LPCs and hospitals to say, look, we think this is important work, help us to get it off the ground. Now, thankfully, that work has been recognised centrally, and there are two really important policy levers that I know as community pharmacists and as any hospital colleagues on the call tonight will be interested in. So first of all, as part of the long-term plan that the NHS England published a couple of years ago now, the community pharmacy contractual framework set out over 5 years where community pharmacy would hope to be commissioned. And as part of that, in year 2, which is the year that we're currently in, it talked about introducing a medicines reconciliation service as part of transfer of care around medicines. Now, it also importantly talked about the phasing out of medicines use reviews. So one of the things we might want to talk about in the Q&A is where does the new medicine service and medicines use reviews fit into that? And you'll see that actually there are a number of kind of hooks we can hang this work on. Those of us that have been involved in the AHSNs in setting all of this up have been able to communicate with NHS England, and the Discharge Medicine Service, as it's going to be called, we now know will start to happen, we think, in the new year. That will be a commissioned essential service. We don't know all of the details of that, but we are confident that the work we've done under Tcam has played a very important role in how that discharge medicine service will look. So for those of you in Berkshire, this isn't work that is going to kind of come to an end and be replaced by something else. This is very much the foundations for you being ready for that discharge medicine service. So that's the first sort of policy area, and I'm sure you'll want to ask questions about that later on. The second area, Sam, if you could go on to the next slide, is around ensuring that hospitals do their part. So obviously, as community pharmacists, you can't act on a referral if it never comes your way. So in the NHS standard contract this year, hospitals were charged, in fact, CCGs were charged with saying to trusts, can you start to have a plan around a transfer of care piece of work? So we've got two very, very important policy levers there upon which this work can now build. And there's lots of resources on the website there at the bottom that you see. So finally, just to finish then, just to kind of reassure you that in Berkshire, you're not, if you go on to the next slide, please, Sam, you're not in any way guinea pigs for any of this. This is a sort of tried and tested rollout, if you like, now that's happening. We've got 62 trusts around the country that are already live with Tcam. And last year, they made 103,000 referrals to community pharmacy, with about over 62,000 of those being taken up by the community pharmacist and acted upon and completed. And I just had a quick look tonight actually at the figures for the last 2 quarters, obviously for this year, which has been an incredible year in terms of services and the way the NHS operates. But Tcam has actually maintained over the COVID period. So whilst we were discharging patients rapidly in February, actually the number of Tcam referrals didn't drop significantly. And so far this year, over 47,500 referrals have been made. There's been a very slight drop in the proportion of those being acted upon by community pharmacy, but I guess some of that's quite understandable if you know, knowing the pressures you were all under in that kind of February, March, April period for dispensing prescriptions. So this is a service that held its own in a crisis because it's really important to make sure as we discharge patients more quickly, which we will be doing over this winter, we've got a place to refer them where we know they'll be supported around their medicines. So lots of work gone on, lots of lessons learned, and we're hoping that you in Berkshire will kind of benefit from all of that and have a really slick rollout and kind of hit the ground running. So I'll finish there, but I am around towards the end to answer any questions about the rollout.
Thank you, Claire. Yes, I just wanted to say although I work for the LPC now, I was a pharmacist in community pharmacy in Southampton when the hospital and us went live with this. So yeah, as Claire said, we've seen many referrals. So I think my pharmacy is probably still the busiest. We're about a mile from the hospital and in a very deprived area of Southampton, so not surprising. But I suppose the national feedback of what helps it work is about sharing our key learnings, our understandings. So you know, as part of my new role within the LPC, I was able to help with bridging the piece between Southampton and Hampshire hospitals, who went live last year. So they're a little bit behind Southampton, but it was around taking the learnings that we'd had for Southampton and sharing that on between. And then with community pharmacies, so when we first started, it was remembering to check pharm outcomes. So, yeah, this is a referral that could come through any day of the week to you. Now it's not so bad, checking it anyway for other things, be it consultation service, and we'll all be using it next month for flu. But it was making sure you keep up to date with checking it and that you're acting on those referrals and that you're completing them. But I'll come on to that bit in a minute. What community pharmacists like? So a small survey was done in London with obviously these results. So everybody was happy to receive the discharge information. And there's a bit there around, is it just for information or is there something you need to act on? Over 90% thought that receiving it improved the information they were able to provide to patients. 80% thought receiving the discharge information saved time, and 64% made an intervention as a result of that referral. And I think that's key, is those bottom two. Certainly for me, saving the community pharmacy time, key, certainly in these current times. Not having to run around and try and find out what medicines this patient is supposed to be on now they've come out of hospital. They know they've had a medication change in hospital, but they've got no notification of it, and they've come into you for a new supply and you've got no prescription and it's not on their repeat prescription or their summary care record. So that's a biggie. Sam, if you'd like to go on to the next slide. So yes, some of the benefits. Improved patient care, most definitely. You know, having spoken to lots of patients, carers, family, relatives of patients that I've served, they found it really reassuring, having come out of hospital, that they actually understand what they're on now, what the changes are, and, you know, and that information is coming through to the pharmacy as well as their GP surgery. Reduced readmission rates, Claire touched on, and reducing the incidence of avoidable harm. So part of mine, probably half of my business, is around nomad trays, and it's making sure that we're not doing unnecessary dispensing and giving old medicines to patients that they're no longer supposed to be taking. It also enhances the collaboration with GPs and secondary care. I have to say, certainly sort of, you know, within the pharmacy, prior to Tcam, how many times did I actually speak to the hospital pharmacy team? Hardly ever. With the introduction of Tcam, probably most weeks. So yeah, so it certainly helps to build that relationship, and obviously cutting down on those unintended errors. Improving medicine support for patients, so particularly around new medicines service. So big push on our patch around DOACs. People know how, when, side effects, etc. And a significant improvement in medicines adherence, which is obviously, again, the new medicine service is designed for. But something I found with patients on new medicines, so not necessarily on nomads, is obviously you get to the end of the month, they've come out of hospital with enough medication for, and actually they then suddenly need to order it again, and it's not on their repeat system because the GP's never prescribed it. They're not too sure that they're supposed to continue taking it. There are lots of kind of issues around that, and actually as part of you having this information, you can remind them that they need to order it, and it also cuts down on that and making sure they continue to take it. So trying to put it into a bit of context, really. So because you probably sat there thinking, sounds like a lot of work, not being paid, so what, why should I do it? I work in a pharmacy that does around about 12,000 items a month, so a pretty busy pharmacy, and I see probably 5 referrals maximum a week. So you're not looking looking at huge numbers. I think most pharmacies, the average will see sort of 1, 2 referrals. I know on our patch we've got some who still haven't seen any. So it really does vary, but yeah, just to put it into kind of context, I'd be surprised if you were seeing more than 5 a week. And I suppose it's about finding what works for you in your pharmacy. No pharmacy is the same. There is no right or wrong way. I used to print out the summaries, the screens you'll see, because actioning it, or it would be my technician actioning it if it was for a nomad tray. We'd use the printout to take to the GP surgery to share that information. And actually, we need to order these new medicines. You'd often find the surgeon actually processed the discharge letter at that point. So we actually would give them information that they hadn't yet processed. But again, for new medicine service, I have the information there to hand to follow up with the patient. And again, to make that reminder to make sure they were ordering their prescriptions towards the end of the month with a new medication. So it is about finding what works for you, and it probably will take you a few to figure out sort of what is the information coming through, what do I need to do with it. One thing, and I know you'll come on to how it all works on farm outcomes in a bit, is to make sure you complete the record. So although you might accept it and then you'll see all the data, it is making sure that you do go back in and finish it off and complete it. So not only does it provides us sort of anonymized data, but also it removes it from your front end screen and saves it. Taking up space there is a hint from me. But yeah, I'll be sticking around as well. So happy to answer any questions anybody might have. Thank you. Next slide, Sam.
Hi, everyone. It's really great to have heard from Alison and to see the process from a community pharmacist perspective, and it's really enlightening. My name, for those who don't know, is Ade Ukoha. I am the Associate Pharmacist at the Royal Berkshire Hospital. I'm also the Pharmacy Clinical Services Lead for the Trust. I just want to express how excited I am about the Tcam process and the opportunity that it provides us to work collaboratively with our community pharmacist colleagues in delivering, and improving patient care. Before I go into the slides about the patient journey, I just want to give a brief introduction to the clinical pharmacy service at the Royal Berkshire Hospital. So our service is made up of a team of about 42 staff members, which includes pharmacists and medicines management technicians. And we provide a service to about 550 beds across the RBH Trust, across 30 wards, covering about 12 specialties. Each specialty is covered by a team of pharmacists or MMTs and is led by a specialty lead pharmacist. And my purpose of just giving the general structure of the clinical service team is to assure you, particularly our community pharmacists, that every patient that we refer to you is looked after by a team of pharmacists and MMTs, so that we work as a team, and we really want to see our community pharmacists as a part of that team in delivering, the best care possible to our patients. Our intention is that we work together, to ensure that patients' medicines are optimized and that we provide the best possible outcomes for our patients. So we really welcome this process, and our aim is that we work together to achieve the best we can for the patients. I'll go on now to the patient journey as we see the patient come through, starting from their community setting into our hospital, either through planned care or through the emergency department. When the patient comes in, they get triaged to a specialty and then get clerked by the doctor who would take on a, basic drug history. Following that, the patient goes into an admissions unit, whether it's the surgical or medical admissions unit. And it's at that point that they meet with a member of pharmacy who would, take down medicines reconciliation. This is where the Tcam journey, so to speak, begins for the patient. At the point of undertaking a medrec, the pharmacist or medicines management technician will first of all consent the patient to check that they're happy for us to share their information with their nominated pharmacy, and we would identify what the nominated pharmacy is and document that information on our EPR system. The next stage in the patient's journey would be us, a member or one of our pharmacists, reviewing the drug chart and validating each medicine on the drug chart, and reviewing the medicines reconciliation. This is an opportunity for the pharmacist to identify whether there is any information that might need to be referred. So we start that process right at the beginning of the patient's journey, and any issue that may have any changed medicines or maybe a new condition, a new diagnosis that will require a change to their medicines will be documented within the form on the EPR system. This will also continue through the patient's inpatient stay. As we know, during their inpatient journey, so many different things may occur, and the pharmacist looking after the patient through the inpatient stay will document whatever is appropriate on the Tcam form, waiting for that information to be processed at the end of their journey, which is the discharge. So once a decision is made to discharge the patient, we expect that there would have been a seamless flow of information from discharge through to inpatient stay and through to the discharge that will now be collated by the discharge pharmacist, who would, decide what the relevant information is, and at the point where the medicines have been validated and screened for discharge, the information to be transferred to the community pharmacist will be finalized and sent off at that stage. There's the details of the type of information or the type of patients we will be referring, the actual information the community pharmacist will be receiving, and how to contact us if there are any issues will be delivered by my colleague Anand. So we can move to the next slide for the nuts and bolts of the process from RBH. Thank you. Would you move to the next slide, please, Sam?
Thank you very much, Adi, for the introduction. And firstly, I would like to echo the words that Adi has mentioned. We're really excited about improving our collaboration, working relationships with the community pharmacies, and also putting our patients first and be able to provide the best services. So the good news is that we won't be referring every patient that gets discharged and every patient that the pharmacist will be reviewing. However, there will be specific criteria that we have picked, and these are the types of patients who are at slightly higher risk of greater impact, patients who have been newly started on any medications. And these kind of patients, the types of medication changes that we're looking at, so it could be a dose increase, it could be changes in frequencies, it could even be small timing adjustments to medications but have a big impact for the patient. And also we're looking at high-risk medications, so this could be anyone who has changes to their Parkinson's medications, any epileptic medications, and any of the medications that have neurotherapeutic monitoring drugs. But potentially the types of other patients that we'll be referring will be the elderly patients, so patients who may be confused or muddled about the medications, potentially people who may need extra information about their medications, as it can be quite stressful for any patient to be admitted to hospital. And being able to remember all of the vast amounts of information our clinical pharmacy team deliver to each patient might not always be on discharge, but it could be throughout their patient stay. And on the previous slide, we mentioned about continuously counselling patients on new medications or even stopping medications. And I think it's really important to be able to reiterate this message again back to the patients when they do leave hospital, and allowing them the chance to be able to remember the information that we have given them whilst in their inpatient stay. And also some of the other types of patients would be the monitored dosage system patients who have boxes where regularly in hospital we do make changes to these medications, and we also create new dossier boxes within the hospital setting and give this to the patient. So when we deliver this to the patient, we may only give 2 weeks worth of medications, and if we did make changes, what happens to the dossier boxes after 2 weeks? So this is where we do really rely on community pharmacies to be able to continue the medications accurately as well. And we do know that sometimes the GPs may not have processed our discharge paperwork, and therefore changes to medications may not always appear on the repeat prescriptions, and therefore utilising community pharmacists when they are screening any of the medication and dossier boxes will be is definitely value to the patient. Next slide, please. So some of the referrals also that we're looking at is based on the framework Prevent 5, which some of you may have seen already. So I know this is quite a busy slide, so I'll touch on some of the main ones that we'll be referring. So patients who have medicines adherence issues, at the end of the day, if the patient doesn't take the medication, they won't get any benefit from the medications. So any of the patients that might have compliance issues, potentially patients who have overdosed on their medications, maybe we've reduced some of their frequency of medications, or want to reduce the quantity of medication supplied to the patient. Also patients who have a cognitive impairment, so patients may have forgotten to take the medications or potentially are on the dossier boxes and need regular reminding that what medication that they are taking. And also the new medications, as mentioned, so any changes to medications is really important so that they do get transferred to the community pharmacies, as ultimately you will be looking after their long-term medication requests and continuing their delivering of medications to them. So being able to accurately dispense the correct medications, as within hospital, like our colleagues have mentioned before, we do make a lot of changes to patient medications, starting, stopping, dose tweaks, and actually for pharmacists, we have this is one of the moments where we do have a lot of impact on patient safety as well. Next slide, please. So the type of information that will be sent to pharma outcomes will be a complete list of the medications on discharge. So if the patient is taking aspirin 75 milligrams, this will be documented in the referral, and the directions as well. The quantity that we'll be supplying, and also a little message next to it, which would say something along the lines of POD, pre-pack, or OSD. And on the right-hand side, I've abbreviated what they all mean. One-stop dispensing means that it has been dispensed already within the hospital pharmacy, and the medication is present on the ward. There will also be a pharmacy supply on there as well, so you know which medications we have supplied. We'll also be sending across a list of allergies as well, so that maybe if you are dispensing any medication or having a look at any of the changes, you can also see a list of their allergies the patient may have. And lastly, we'll be sending a comments box. So in the comments box is where we'll write all the main information that we want you to action, and the reasons why we have referred the patient in the first place. So in the reason referral, we'll document something along the lines of patient has newly started on the Bigatran. Please can you review the medication in 2 weeks' time to check that they've correctly and dose reduced. We'll also be sending information about the medicines in a dossier box. So potentially the number of weeks supplied, whether the medication is inside the dossier box or whether the medication is outside of the dossier box, and how we have actually discharged the patient from hospital. We'll also highlight some of the changes to the medications as well. So this will include increase of doses and stopping of medications. Also, any short courses of medications that we're supplying, so let's say a short course of steroids, and they're not going to be continuing it, we may add this information in. And also any specific follow-up requests that, that we think the patient would benefit from. So, for example, if we did start the patient on a new inhaler, and we counsel them on how to use the inhaler, and they could effectively use the inhaler very well, they may need a reiterating of how to use the inhalers back again in community, or a simple message such as if we've dispensed new trays, we may need to remove the old trays from the patient. And this is because when the elderly patients come in, we don't always have the opportunity to ask their relatives to return their medications back to the chemist, even though we give this information back to the patient on discharge. But having a second check in community will be really helpful, and this will prevent the patient being able to, or taking the old medications and preventing harm. The other information that we'll be sending would be the name of the pharmacist who has screened and validated the medications on discharge. And this will be useful so as a contact as well. Ultimately, the information that we'll be sending, it will be the things that we've identified and what we feel would be beneficial to the patient upon discharge in community. And this will be this will allow you to improve some of your communications and collaboration with the patient, and also build up the better relationship with your patients as well. So if the patient will be usually these patients are long-term patients within your area, and a bit more about their history, and if they do come to you every month or so, and they've recently been discharged from hospital, you could follow up with some of the questions and see how they get along with their new medications, or if they are experiencing any side effects with any medications, and whether you'll be able to help them with providing any additional pharmaceutical interventions. So ultimately, the decision of the information that we give will be up to you, the community pharmacist. So we will just sit there here and provide as much information as we can. Thank you. Next slide, please. So what do you do if you have a question or a query? So there'll be lots of information that will come through. And thankfully, it'll only be a list of drugs and the things I mentioned before. You won't get the whole GP copy of the information that we do send to GPs. And we'll be supplying the name of the pharmacist on the pharma outcome referral, and the telephone number will be the hospital switchboard, and a bleep number. So every pharmacist within the hospital team carries their own bleep number. And the question then would be, okay, when you receive this referral, is it an urgent query or is it a non-urgent query? And if you find that actually it's an urgent query that you need to sort out then and then what you need to do is dial the hospital switchboard number and then connect via a bleep number. If you get no answer after bleeping twice, or maybe you might get a message saying that the bleep is switched off, then do contact the main inpatient pharmacy via switchboard and put it through. If it's a non-urgent inquiry, please send us an email at medicines.information@royalberkshire.nhs.uk. This will be generally manned by the medicines information team. However, we will try and endeavour to respond back to your queries within 24 to 48 hours. And this will be a good way for us to be able to relay information back to the hospital. So even if it is a different pharmacist, do document things like the patient hospital number, potentially a date of discharge. Give us as much information as you can about your query, and we'll follow up and get back to you as soon as we can.
Yes, thank you very much. And I just want to reiterate what everyone has said before me. Very proud to be able to talk about Tcam tonight, and thank you to all our colleagues at the Royal Berks and to AHSN, to the staff at Farm Outcomes, and to Alison for joining us tonight, so thank you to her. Now, you'll be pleased to know that I've only got 3 slides. That's how simple the process is. Otherwise, I wouldn't be explaining it to you now. So you should be fully aware of how Farm Outcomes works. We've been using it now for quite a number of years. And the new CPCS referral service dictates that you should be checking your Farm Outcomes at least daily anyway. And of course, with the onset of the flu service as well, you'll be using farm outcomes far more often than that. So that's the key to this at the moment, is to make sure that you go into farm outcomes every day and check to see whether you've got a referral. So all you have to do is click the services tab and you'll see whether you've got any referrals for you on behalf of the Tcam service. Next slide, please. So you'll see here that there's a list of unprocessed referrals. So they're found under outstanding. And you'll see that they have a pending status and will remain there until you've dealt with them. So if you want to look at a Tcam referral, just click on the referral to access the information. Next slide, please. And there you can see is all the information that our colleagues from the Royal Berkshire was talking about. All the information they've put in is pre-filled into this top box that's got a grey background. And you've even got the patient's telephone number there. So you can use that to make contact and use it to make an appointment for an MUR or an NMS. And you can also see the reason for the referral, whether there's discussion about potentially a home delivery, an MUR, whether there's a smoking cessation opportunity as well. And as Alison said earlier on, you must be sure that once you've accepted, you complete the referral. Otherwise, that will sit in your pending pile for quite a while. But you've also got the choice to reject a referral for whatever reason. And obviously that reason will be down to you, in terms of maybe there's an issue with a patient or a mistake's been made, and you can reject it, and that will go back, I believe, to the hospital to be referred out again. So as you can see, this is a very, very simple process, a process that you should be used to doing in terms of farm outcomes, and something which I think you'll find will really promote collaboration, which is a word you've heard many times this evening, with ourselves and with the Royal Berks. Now, there's a video on our website at pharmacythamesvalley.org.uk where you can see a bit of a simplified working process with our friend Gary Warner narrating it. We've also got a template SOP on our website. So for those smaller pharmacies, you can print that off and use it as a training aid and as a record of acceptance of the SOP in your pharmacy. There's also an FAQ and a user guide to help you work through the farm outcomes process once it hits community pharmacy. But once again, thank you to everybody this evening. And I'm looking forward to monitoring all those referrals that will be coming in, and obviously all the fantastic patient outcomes that will arise from that. Next slide, please.
Well, ladies and gentlemen, that brings us to the end of the presentation. What I'll do now is I'll leave up this slide, which is the FAQs, for you to read at your own speed. But we will post a link to this presentation to you in the next few days via the LPC. In the meantime, shall we have a look at the questions that were posted in the chat? Have we got any questions posted in the chat? Does anybody know? No, I think they look blank to me. So does anybody want to ask any questions? If you do, don't forget to unmute yourself before you try to speak.
Hello?
Hello?
Hello, I did actually put through a question in the chat about does this referral happen once the patient has been discharged or just to a planned discharge? Because we have had issues, not recently, but in the past, where a planned discharge hasn't happened.
Thank you.
Vivian.
Thank you, Vivian, for your question. So the way the process will work within the hospital would be that once they've been flagged for discharge, the pharmacist review the medications. We have it interlinked within Cerner, our prescribing system, so that once the patient, we've screened the patient and we've completed all of their medications, once the patient has been discharged physically from the system and the information gets sent to the GP, at that same moment, the information will get sent to your community pharmacy. So it will be at the point of discharge from when the patient has left the hospital.
Thank you.
We don't seem to have any questions in the chat, and I think Vivian said she did type some, so I'm not aware if they've been deleted or if they've been lost somewhere, but I would suggest that if you do have a question that you just unmute yourself and pose it again.
Hi, can I ask a question, please? So if the patient is not registered with your pharmacy, could we still carry out the service if we phone the patient is happy for us to do it, or no, we have to refer it to their pharmacy?
Thank you for the question. So the process within the hospital would be that on admission, and when we review the patient, we'll be asking for their consent first. Once we've got the consent, we would also confirm their local community pharmacy, and this we can see via the summary care records, or also confirm with the patient what their regular community pharmacy is. Now, if it's something different to their usual one on the summary care records, then we would document this information down, and as long as the patient is happy, this is where the referral will come to. So the referral will only get sent to the pharmacy that we select from within the hospital.
It's Claire here. I'm just thinking that, so the way the service was set up is ideally it is for the patient's usual community pharmacy. So if you receive one and it's clearly not your patient and in a geographic area, it's worth checking with the patient, because sometimes patients don't always go home to their home. They may go and stay with their sister or somebody else. So that sometimes is a factor. But if it isn't a patient that is, you know, somebody who will be getting their prescription for you, it's best to, I guess, reject it and make sure that goes to their usual pharmacy. Alison, I don't know whether you have picked up a few of those and whether you routinely reject them when it's clearly not your patient.
Yeah, I have to say I've only ever seen a couple. Most of them seem to be accurate. But yeah, no, I've normally have a conversation with the patient on the phone number that's been given to ascertain, yeah, whether they're staying with a relative. So therefore, yeah, they're going to start using my pharmacy, or if it's come to me in error. And then if it's come to me in error, I will reject it and send it back to the hospital.
Any other questions?
One thing I was going to pick up on, Matt, that Alison touched on it, and obviously the hospital colleagues at RBH clearly expressed their keenness that this improves relations between the hospital and community pharmacy. But I think Alison and I would both say in Wessex, you know, we've been up and running with this service in Southampton and across Hampshire hospitals for a number of years now. And I think, you know, we can absolutely say that on a local level, it improved relationships, because as Alison said, she may never have phoned the hospital before, but now that happens through Tcam. But also we as the AHSN, we host about every 6 weeks or so meetings with the LPC, the CCG and the Trust to iron out any issues or any problems. And that collaboration has had lots of really positive benefits for the system as a whole. So as we move more into this kind of system working and we're working much more closely together, Tcam's been a real enabler for that. So there are benefits for the patients, but there are some wider benefits. And I think our experience from Wessex has been, that's been absolutely real. So I hope you have exactly that experience in Berkshire and around the Reading area, because it's been fantastic for us to be part of that, and the knock-ons have been significant, you know, broader than Tcam, which is great. And I think as community pharmacy, sometimes you feel a bit outside of it, and this is one of those services where, you know, you're absolutely at the heart of this, and so for me it felt really great that we're, you know, finally bringing community pharmacy in the place they absolutely belong, which is right at the heart of the medicines pathway.
Definitely, and I reiterate what Claire says there. You know, from having it introduced to, you know, suddenly actually you've got that relationship with the local hospital pharmacy team. You know, they will actually pick up the phone to the community pharmacy, often when the patient's admitted, to find out some information, as well as when they're about to be discharged. seeing, and then sending a Tcam. So it's very much, the community pharmacies into a wider team to be able to support that patient.
I have another question, if that's all right.
Yeah, sure, please.
Right. Previously in the past, we have had calls from hospitals asking us to make up nomad trays so that a patient can be discharged. Will this service be used for that?
Can I answer that one?
Yes.
Yeah, my understanding is that the Royal Berks will discharge with 2 weeks supply of a tray already done in-house. So you won't have to do it on discharge.
Always.
But what I will ask
okay.
is, it's your discretion as the dispensing pharmacist to review the need for a tray going forward using a quality assessment form, which we have on our website. And if you work for one of the multiples, you've probably got your own version.
No.
And it's always going to be your decision whether that patient will continue the tray, because the reasonable adjustment needed might only be they have larger labels or easy open bottles, or indeed they've now got a carer, so they don't need to have nomads. So don't think that you need to continue nomads if that patient's been given nomads on discharge. That's purely your assessment based on clinical need and DDA in your pharmacy.
Thank you.
Could I just also add on to that as well? So you're right. So we will always discharge the patient if they did come in on a nomad. However, there might be very rare occasions where we may have to contact the community pharmacy and to see potentially, let's say if they've got some repeat medications there, if we are not able to dispense the medications, let's say if it was after hours, or let's say, when I mean after hours, I mean 5 or 6 o'clock in the evening, and this could be for the next day going delivery. The other thing is that we wouldn't be using pharma outcomes to send this information to local communities. So it would always be a verbal communication via the phone, followed by sending information via .nhs.net. But this will be a very, very rare occasion.
Thank you.
Any more questions? I'll give you just a few seconds to work out how to unmute your microphone if that's what you're trying to do. Otherwise, if there are no more questions, then I think it's about time we bring this meeting to a close. Thank you all again for your time this evening. I'm sure you'll join me in offering a huge thank you to all our speakers, several of whom have given up an evening while on annual leave to be here. And also thank you to my colleagues Sam Collins and Ferdinand Manansala, who have been working hard behind the scenes to make this event work. Without their support, this would have been impossible to do this. All that's left for me to say now is enjoy what's left of your evening and keep an eye out for an email from the LPC with the link to this video if you want to watch it again, and obviously a link to more resources on their website. Thanks very much, and have a good evening.
Yeah, thank you. Good evening, everyone.
Thank you.
Thank you.
Can you end the meeting, Sam?
Yep, that's fine. I'll end the meeting now.
Okay, thanks again, guys.
Thank you. Thanks, Matt. Thanks, Alison and Anand.
Good luck with it.